Welcome to the Cannabis Risk versus Benefit Learning Module Section 2, Clinical Evidence. In 1999, the Institute of Medicine issued a report discussing the clinical evidence for cannabis. In the discussion of cannabis abuse and dependence in this report, the conclusions were drawn that few cannabis users develop dependence, the symptoms of cannabis withdrawal are mild and short-lived, and there is no conclusive evidence supporting the idea of cannabis as a gateway drug, and the data does not support that the use of cannabis for medical purposes would lead to a pattern of drug use similar to what is seen in illicit use. This was important in removing the long-standing bias towards the use of cannabis medically. The Cannabis for the Management of Pain Assessment of Safety study was published in 2015. This prospective cohort study followed individuals with chronic non-cancer pain over a 1-year period. Non-cannabis users with non-cancer pain from the same clinics were used as controls. The primary outcome of this study was to assess serious and non-serious adverse events. Secondary outcomes were to assess pulmonary, neurocognitive, renal, liver, and endocrine function, as well as standard hematology and biochemistry. Secondary efficacy measurements included pain, mood, and quality of life. Plant cannabis with 12.5% THC was used. Patients were allowed to self-titrate their dose with a maximum recommended dose of 5 grams per day. This Canadian study is the first long-term safety assessment study conducted on cannabis. The study concluded that medical cannabis use did not increase the risk of serious adverse events as compared with controls. It also concluded that medical cannabis was associated with an increased risk of non-serious adverse effects, particularly with respect to the nervous system and psychiatric disorders. Medical cannabis users also had a higher rate of developing non-serious respiratory adverse effects during 1 year of follow-up as compared with controls. This is consistent with the smokable dosage form used within the study. No differences were found between cannabis users and controls in secondary safety assessments. However, medical cannabis users had significant improvements in pain intensity and physical dimension of quality of life, as well as in measures of the sensory component of pain, symptom distress, and total mood disturbance over a 1-year period as compared with controls. The final conclusion of the study was that quality-controlled herbal cannabis appears to have a reasonable safety profile. The National Academies of Sciences, Engineering, and Medicine published a 2017 report entitled The Health Effects of Cannabis and Cannabinoids, the Current State of Evidence and Recommendations for Research. The goals of this report were to develop a comprehensive, in-depth review of the existing evidence regarding the health effects, both harms and benefits, of cannabis and cannabinoids. Additionally, the goal was to make short and long-term recommendations regarding a research agenda to identify the most critical research questions and advance cannabis and cannabinoid research. This report has largely become the gold standard when discussing the current state of the evidence for medical cannabis therapy. More than 10,000 abstracts were considered by the committee for the report. Preference was given to recently published systematic reviews and high-quality primary research that studied one or more of the 11 health outcomes identified as a priority. Basic, non-human research was not included in the review. The review also primarily included research published before 2017. The 11 health outcomes identified as a priority are therapeutic effect, cancer incidence, cardiometabolic risk, respiratory disease, immune function, injury and death, prenatal, perinatal, and postnatal outcomes, psychosocial outcomes, mental health, problem cannabis use, and cannabis use and abuse of other substances. Conclusions of the committee were categorized into 5 levels of evidence: conclusive, substantial, moderate, limited, and no or insufficient. It is important to note that a lack of evidence cannot be interpreted as a lack of effectiveness. It simply indicates there is insufficient evidence to draw a conclusion one way or the other. The report concluded that there is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults, as antiemetics in the treatment of chemotherapy-induced nausea and vomiting, and for improving patient-reported multiple sclerosis spasticity outcomes. The report concluded there is moderate evidence that cannabis or cannabinoids are effective for improving short-term sleep outcomes in individuals with sleep disturbance associated with obstructive sleep apnea syndrome, fibromyalgia, chronic pain, and multiple sclerosis. It is important to note that the clinical trials for Epidiolex had not been completed at the time of this review. As of 2020, there is conclusive FDA-approved evidence for the effective use of cannabinoids, specifically cannabidiol, in the treatment of seizure disorders. The report concluded that there is limited evidence that cannabis can be effective for increasing appetite and decreasing weight loss associated with HIV/AIDS, improving clinician-measured multiple sclerosis spasticity symptoms, improving the symptoms of Tourette syndrome, improving anxiety symptoms as assessed by a public speaking test in individuals with social anxiety disorders, and in improving symptoms of post-traumatic stress disorder. There is also a limited evidence of a statistical association between cannabinoids and better outcomes after a traumatic brain injury or intracranial hemorrhage. Additionally, there is limited evidence that cannabis is ineffective for improving dementia symptoms, improving glaucoma intraocular pressure, and reducing depressive symptoms in adults with chronic pain or multiple sclerosis. The report concluded that there was no or insufficient evidence to support or refute the conclusion that cannabinoids are an effective treatment for cancer, cancer-associated anorexia, anorexia nervosa, symptoms of irritable bowel syndrome, epilepsy, spasticity in patients with paralysis due to spinal cord injury, symptoms associated with amyotrophic lateral sclerosis, chorea, and certain neuropsychiatric symptoms associated with Huntington's disease, motor system symptoms associated with Parkinson's disease or levodopa-induced dyskinesia, dystonia, achieving abstinence in the use of addictive substances, and in mental health outcomes in individuals with schizophrenia or schizophreniform psychosis. Again, it is important to note that epilepsy now has sufficient conclusive FDA-approved evidence for the effective use of cannabinoids, showing that science is constantly evolving. And just because there is no or insufficient evidence for these symptoms or disease states does not mean that cannabis does not represent a potentially effective treatment option. Further studies are needed in order to elucidate whether or not cannabis can be effective for these patients. In looking at adverse events associated with the respiratory system, the report concluded that there is substantial evidence of an association between cannabis smoking and worse respiratory symptoms and more frequent chronic bronchitis episodes associated with long-term cannabis smoking. There is moderate evidence of an association between cannabis smoking and improved airway dynamics with acute use, but not with chronic use, as well as higher forced vital capacity. There is moderate evidence of an association between the cessation of cannabis smoking and improvements in respiratory symptoms. There is limited evidence of an association between cannabis smoking and an increased risk of developing COPD when controlled for tobacco use. there is no or insufficient evidence to support or refute an association between cannabis smoking and hospital admissions for COPD, asthma development, or asthma exacerbation in patients. In evaluating the association of cannabis and cancer, the report concluded that there is limited evidence of a statistical association between cannabis smoking and non-seminoma type testicular germ cell tumors. This is highly likely due to the fact that both are common in men aged 18 to 40. However, further research is needed to determine if this association has a causal effect. The report also concluded there is moderate evidence of no association between cannabis use and the incidence of lung, head, or neck cancers. It also concluded there is no or insufficient evidence to support or refute an association between cannabis use and the incidence of esophageal, prostate, cervical, bladder, penile cancers, malignant gliomas, non-Hodgkin lymphomas, Kaposi sarcoma, or the development of acute myeloid leukemia or acute non-lymphoblastic leukemia, rhabdomyosarcoma, astrocytoma, or neuroblastoma in offspring. The lack of an association between cannabis smoking and cancer can seem confusing when there is such a clear link between tobacco smoking and pulmonary cancers. First, it is important to note that very few individuals smoke 20 to 40 cannabis cigarettes a day the way that they smoke tobacco cigarettes. Secondly, cannabis has anti-inflammatory, antioxidant, and potential anti-tumor qualities, which tobacco does not. When these factors are taken into consideration, the lack of an association between cancer and cannabis use makes much more sense. The report concluded on the adverse effects of cannabis and cardiometabolic risk that there is limited evidence of a statistical association between cannabis use and the triggering of acute myocardial infarction, incidence of ischemic stroke or subarachnoid hemorrhage, decreased risk of metabolic syndrome and diabetes, or increased risk of prediabetes. It also included there is no evidence to support or refute an association between the chronic effects of cannabis use and the increased risk of acute myocardial infarction. The report concluded on the adverse effects of cannabis in regard to immunity that there is a limited evidence of an association between cannabis smoking and a decrease in the production of inflammatory cytokines in healthy individuals. It also concluded there is limited evidence of no association between cannabis use and the progression of liver fibrosis or hepatic disease in individuals with viral hepatitis C. Finally, the report concluded there is no or insufficient evidence to support or refute an association between cannabis use and other adverse immune cell responses in healthy individuals, adverse effects on immune status in individuals with HIV, or increased incidence of oral human papillomavirus. In assessing the adverse effects of cannabis and injury or death, the report concluded there is substantial evidence of a statistical association between cannabis use and the increased risk of motor vehicle crashes. It is important to note that the magnitude of effect within the study was weakened when accounting for alcohol intoxication. This association also relies on the fact that cannabis is now more frequently detected in motor vehicle accidents. However, there has not been a significant or sustained rise in the number of accidents in jurisdictions that have legalized medical or recreational use. This association might simply mean that more drivers are being tested for cannabis, which would mean more drivers are cannabis positive without necessarily establishing a causal link. However, further studies would be needed to determine the association and whether or not causation also is in play. The report also noted moderate evidence of an association between cannabis use and an increased risk of overdose injuries, including respiratory distress among pediatric populations in U.S. states where cannabis is legal. The report concluded there is no or insufficient evidence to support or refute an association between cannabis and mortality, occupational accidents, or death from cannabis overdose. Where pregnancy is concerned, the report concluded there is substantial evidence of an association between maternal cannabis smoking and lower birth weight of the offspring. The report also found limited evidence of an association between maternal cannabis smoking and pregnancy complications for the mother, or admission of the infant to the neonatal intensive care unit. Finally, the report found insufficient evidence to support or refute an association between maternal cannabis smoking and later outcomes in the offspring, such as sudden infant death syndrome, cognition, academic achievement, and later substance use. The adverse effects of cannabis from a psychosocial perspective were concluded as having moderate evidence of a statistical association between cannabis use and the impairment in the cognitive domains of learning, memory, and attention with acute use. There is limited evidence of an association between cannabis use and impaired academic achievement and education outcomes, increased rate of unemployment and/or low income, or impaired social functioning or engagement in developmentally appropriate social roles. There is also limited association between sustained cannabis abstinence and impairments in the cognitive domains of learning, memory, and attention. The conclusions drawn by the report on the association of cannabis and mental health have been the subject of much debate. The report concluded that there is substantial evidence of an association between cannabis use and the development of schizophrenia or other psychoses with the highest risk among the most frequent cannabis users. The report also concluded there is moderate evidence of an association between cannabis use and better cognitive performance among individuals with psychotic disorders and a history of cannabis use, increased symptoms of mania and hypomania in individuals diagnosed with bipolar disorders, a small increased risk for the development of depressive disorders, increased incidence of suicidal ideation and suicide attempts with a higher incidence among heavier users, increased incidence of suicide completion, and increased incidence of social anxiety disorder. However, there is moderate evidence of no association between cannabis use and the worsening of negative symptoms of schizophrenia among individuals with psychotic disorders. In an interview regarding the conclusions of the report, Dr. Igor Grant stated, quote, "In fact, there has been no increase in diagnosis of schizophrenia in Western societies during the 5 decades since recreational cannabis use became prevalent. A more cautious interpretation of the cannabis schizophrenia association may be that different elements of psychopathology travel together, perhaps reflecting influence of some common vulnerability factor or factors, with problematic substance use being one of those indicators." Unquote. This is a way of explaining once again that association may or may not equate to causation, and more research is needed to determine exactly what the association between cannabis and schizophrenia means. Additional mental health conclusions of the report stated there is limited evidence of an association between cannabis use and an increase in positive symptoms of schizophrenia, the likelihood of developing bipolar disorder, the development of any type of anxiety disorder, increased symptoms of anxiety, or increased severity of post-traumatic stress disorder symptoms. It also concluded there is no evidence to support or refute an association between cannabis use and changes in the course or symptoms of depressive disorders or the development of post-traumatic stress disorder. When it comes to the adverse effects of cannabis and substance abuse or misuse, the report concluded there is substantial evidence that stimulant treatment of attention deficit hyperactivity disorder during adolescence is not a risk factor for the development of problem cannabis use. Also, that being male and smoking cigarettes are risk factors for the progression of cannabis use to problem cannabis use, and that initiating cannabis use at an earlier age is a risk factor for the development of problem cannabis use. The report concluded there is substantial evidence of an association between increases in cannabis use frequency and the progression to developing problem cannabis use. Also, that being male and the severity of problem cannabis use, but the recurrence of problem cannabis use does not differ between males and females. The report stated that there is moderate evidence that anxiety, personality disorders, and bipolar disorders are not risk factors for the development of problem cannabis use. That major depressive disorder is a risk factor for the development of problem cannabis use. That exposure to the combined use of abused drugs is a risk factor for the development of problem cannabis use. That neither alcohol nor nicotine dependence alone are risk factors for the progression from cannabis use to problem cannabis use. And that during adolescence, the frequency of cannabis use, oppositional behaviors, a younger age of first alcohol or nicotine use, parental substance use, poor school performance, antisocial behaviors, and childhood sexual abuse are all risk factors for the development of problem cannabis use. The report also found moderate evidence of a statistical association between a persistence of problem cannabis use and a history of psychiatric treatment, and problem cannabis use and increased severity of post-traumatic stress disorder symptoms. The report found limited evidence that childhood anxiety and depression are risk factors for the development of problem cannabis use. The report found moderate evidence of an association between cannabis use and the development of substance dependence and/or a substance abuse disorder for substances including alcohol, tobacco, and other illicit drugs. The report found limited evidence of an association between cannabis use and the initiation of tobacco use or changes in the rates and use patterns of other licit and illicit substances. In summary, there are many barriers to conducting cannabis research in the United States. Due to these barriers, the majority of the clinical evidence we have for cannabis use is based on observational studies. The risks and benefits of cannabis should be evaluated through drug-drug comparison, safety assessments, and a review of the current clinical evidence. Based on a thorough review of the available cannabis literature, the following conclusions were drawn. Cannabis has shown to be effective for the treatment of chronic pain, chemotherapy-induced nausea and vomiting, multiple sclerosis spasticity, and sleep disturbances. There is an association of cannabis use with increased motor vehicle accidents, low infant birth weight when smoked by pregnant mothers, the development of schizophrenia or psychosis, impaired cognitive function with acute use, and development of problem cannabis use if initiated at an early age. It is important to note once again that these associations may or may not be causal in nature, and further studies are needed to clarify these relationships. This concludes the Cannabis Risk versus Benefit Learning module. Thank you for joining us.